Hey Arnie's. Alright, so you watched the standard induction video. I'm now just going to watch it back with you and I'll kind of do a little voiceover sequence. So the first thing you'll see me do is go ahead and bank my assignments, just who the OR nurse is. The person who's going to serve as the OR nurse is Lieutenant Commander Gutierrez. She's an SRNA in Phase 2, currently right now with USU. She's a former OR nurse, so she's very comfortable in that position. You can hear her say something like, "Oh, it's been over a year since I've done this." But the way that we'll start out the situation with the patient on the bed, so it's almost like you brought them in on the gurney, slid them over onto the operating room bed, and then you start to apply your monitors. You'll see the sequence in which I do it as I put the pulse oximeter on first, just to get a quick room air sat. The very next thing I'm going to put on is a blood pressure cuff because that takes some time to put on. And then I'll go ahead and put on my EKG leads. Normally in this situation, with an elective case, you would have had the room completely ready to go. The EKG leads would have been on the bed already, and so you wouldn't have to untangle it, in which you'll see I'll have to do. And actually, that's sometimes does occur when something gets added on, or maybe you're in between cases and you don't get it completely as set up as you want to, but you're running short of time. So you can get that done in the room. So you'll hear Lieutenant Commander Gutierrez say, this is very realistic. When you see me untangling the cables, and I'll give her, that nod of approval, saying, "Yep, that is very true." So let's go and watch this opening sequence. Oh, actually, Sarah, would you be my OR nurse? Oh, yeah. Awesome. Okay. So patients just moved over. So make yourself comfortable now. We're just going to get our monitors on you. So if you mind putting that on for me, please. I'm just reassuring the patient. So the white and green ones go off to the right, and the brown, red, and black ones will go off to the left side. So if this were an actual female patient, I would provide her some privacy. I would not completely expose her from the waist up by putting on leads, as I would work around and ensure that she maintains her privacy. My monitors include my peripheral nerve stimulator, for the mannequin is the orbicularis oculi is not available, so we use the adductopalacis in this simulation. Alright, man. I'm going to give you some oxygen here. Turn on my oxygen. You start taking some nice, easy, deep breaths, okay? If you wouldn't mind, man, just putting nice, firm pressure on there. The one thing I'm going to do is just make sure my positioning is correct. In real life, I would bring the patient up and readjust because this mannequin is very sensitive. We're not going to readjust. So you can hear me say it. We're not going to move the mannequin, but we want to make sure that the external auditory meatus is above the sternum before you start managing the airway. So the next thing I'm doing is putting in my fentanyl. So I'm going to start working my fentanyl in just 50 mics at a time up to the amount that I want. 2 mics of fentanyl, charge at 150, 2 mics per kilo. So you hear me say my goal is 150. I've just given 50, so I'm going to give again. Aliquots of 50. I want that fentanyl to go in sooner than my propofol. It doesn't peak at the same time. You give another 50 mics of fentanyl. 100. I'm looking at my monitor, make sure I'm getting good end-tidal CO2 tracing, seeing what my fraction of expired oxygen is. 50 of fentanyl. Here's my last 50 of fentanyl. Big deep breath, man. Big deep breath. You're doing great. So next I'm going to do is put my lidocaine in line, making good use of my time while the patient's pre-oxygenating. After this blood pressure, we'll get off to sleep, okay? You see I've got my laryngoscope blade there. I've got the endotracheal tube. Everything's ready. I'm not reaching back constantly to the anesthesia machine, bringing things up one at a time. I bring everything up. Something else that would have been done prior to is the tape for the eyes, but just having the OR nurse make a couple small pieces for me. So make sure you're pre-oxygenated about 0.8 to 0.9. So lidocaine's going in. 100 milligrams of lidocaine. 130 milligrams of propofol. 2 milligrams per kilo propofol. You'll hear me reach up and say, let me make sure that my fluids are flowing. We'll make sure that propofol is just not sitting in line. Deep breath, man. You're doing great. We'll take good care of you. Ma'am, open your eyes for a while. Open your eyes. So in that sequence, if you back it up, you'll see that I'm touching the patient, so shaking her. So a tactile or a physical stimulation. I'm saying her name, and then I do a quick lid reflex. All that's done very, very quickly just to see if she's lost consciousness. So after I do that, then I'm going to reposition the head. Well, you'll see me close the APL valve ever so slightly, and I'll give a mask ventilation. Once I show I can mask ventilate, I'll go ahead and get my rocuronium, press my rocuronium. I know that I can mask ventilate at that point, so I know that I'm not on the difficult airway algorithm. So I take the oxygen off the face because I know I can always put it on and oxygenate when I need to, because the patient's not breathing at this point. Apneic oxygenation is not required at this point. Tape the eyes, give the rock, tape the eyes, and then go right back to ventilating. You'll see that I'll go reach back and turn on the sevoflurane at that point too, because it'll probably been about 30-45 seconds since the propofol has been given. The propofol is peaking, and so that means every second then afterwards that peak propofol is starting to wear off. So I'm past that the depth of anesthesia propofol is going to give me. So I'm going to replace, as the propofol is going off, I'll start onsetting with some sevoflurane as I'm waiting for the rocuronium to onset. You'll see that I'll do a peripheral nerve stimulation too to see the twitches, kind of get a baseline twitches. And then right before I go to intubate, I'll do another set of twitches to show that the twitches are gone. And then I'll go to intubate. Let's watch the sequence. So mask ventilate, prove I can mask ventilate. Good. Rocuronium now goes on because we'll be waiting for the rocuronium. That's the next thing we'll just have to wait on. So let me get that on as quick as possible. We'll go ahead and tape the eyes. Now that I've proven I'm not on the difficult airway algorithm, I can do other things. Slip in my oral airway just to make life easier. I looked at the clock just to see again, so I'll be able to look up and know when 2 minutes has passed by for my rocuronium. And then I go right back to mask ventilating. I'll reach back, turn on the sevoflurane, get a quick baseline. Looking up at the clock, looking at my tidal volumes, looking at my end-tidal CO2. I want to see how big my tidal volumes are with the effort that I'm giving. As the rocuronium goes on, I'll be able to lessen the amount of pressure in the system, so I'll reach over and open up the APL valve a little bit. All very, very common things. As the patient becomes muscle relaxed, it becomes easier to manage. Little increase in heart rate there. getting a blood pressure. One thing I don't know if I pointed out, but right before I induced, I had finished to make sure I got one last blood pressure, just to make sure a patient's been stable before the beginning of induction. If you need to back up and watch that part, and see that, you can. This dilates all the way out. I'm going to back up the tube, so it's about 22 centimeters for a woman, 21 to 22. Then the air goes in the balloon. I'm going to place it in the tree over there. Look at the chest, rise and fall of the chest. Look in the tube to see mist in the tube, and then I look at them on there. So there's an important sequence there to verify that you're in the right place. You have the tactile stimulation, or tactile feel of the bag. It feels like a lung. It's not hard, like the stomach would be if you're trying to put air into there. I look at the chest, I see rise and fall of the chest. I look to the patient, I see mist in the tube, and then I look over to my monitor to see end-tidal CO2. A lot of people want to just look up at the monitor and wait for that end-tidal CO2. That's not where your eyes should go. Your eyes should go to the patient. So if you need to, back up and watch that sequence, okay? Then I'm going to do 4 end-tidal CO2 breaths, and then I'll go ahead and listen to lung sounds. You'll see that I'll listen to lung sounds far on the left side and far on the right side. I do that away from each lung field. If I listen just at the apex on the front of the chest, and sometimes you can actually hear the other side lung sound. So I get as far away as possible, listen, as far away as possible, listen, and then listen to epigastrium. So I gave the OR nurse instruction exactly how I want her to hold it. Not up high, but ground her hand against the patient's face, right at the base. Listen to the far left side. Listen to the far right side. Listen to the epigastrium. I'm going to open the APL valve. Turn on the ventilator. Turn down my flows. Leave them up just a little bit. They're probably at 3 or 4. And then turn on the sevoflurane. And then I'm going to come back and secure the tube. In the beginning, securing a tube can take you 1 to 2 minutes, and that's a long time for the patient. If you're not have the ventilator on, if the patient's not being breathed for, then that means there's no anesthesia going on, as well as no oxygenation or ventilation. Secured my tube. I'm going to clean up the area, bring everything back over to the anesthesia machine area. The last thing I'll do is kind of do my finishing up steps. So I'm going to place my esophageal temp probe. If I want an OG tube, won't need it particularly for this case, then I would place it. And then I would put the bear hugger on and give some antibiotics, and the sequence will be complete.
Esophageal temp probe goes in, OG tube if I want, not for this case. Bear hugger goes on, check the condition.
There'll be slight variations from faculty member to faculty member, just of things that they like to do. But 95% solution, that's exactly what an induction sequence looks on an elective, knee scope, or a generally healthy patient. All right, hope you enjoyed and hope that helps you. We look forward to doing the simulation.